All right,
Go for it.
great. We'll go ahead and get started. Linda, if you want to kick us off.
I will. I will do that. So good morning to everyone from Oregon and good afternoon to those joining us from the East Coast. My name is Linda Wyatt. I want to welcome everyone to the second focus group session for the Oregon Prescription Drug Affordability Board. I am a healthcare senior manager here at Myers and Stauffer, and we are a national accounting and compliance firm supporting government-sponsored healthcare programs. And I am joined today by my colleague, Bobby Courtney, who's a principal here at Myers and Stauffer, and he will be facilitating the discussion portion of today's session. So this meeting is conducted for and on behalf of the Oregon Department of Consumer and Business Services. Information collected and recorded at this meeting is potentially subject to disclosure under a public records request. And to note, we are recording these sessions to ensure that we capture the feedback correctly. If you wish to speak and are uncomfortable with having a specific comment recorded, please let us know and we will temporarily stop the recording. Also joining us today from the PDAB board is board chair Shelley Bailey. And I would also like to introduce Jane Horvath of Horvath Health Policy, who is also supporting the board with their work. So for those who are new to today's meeting, to these sessions, let me just give you some logistics before we jump into the conversation. So as we are beginning today's session, first off, we do want to thank you all very much for attending, especially for those of you who are attending the second meeting. We do know that your time is incredibly valuable, and we do appreciate your willingness to share your perspectives on this important topic. For this second meeting, we will do a quick refresher of just a couple of the slides that were presented at the first meeting, just to make sure everyone is kind of on the same page. And then following the slides, we will continue the constituent group discussions and from meeting one. And as a reminder, our goal on these sessions is to get your perspectives on the use of upper payment limits, or UPLs, to improve drug affordability and gather any recommendations you have on improving drug affordability for Oregonians. And in turn, these sessions will inform the board's work on developing a plan for establishing UPLs as required under Senate Bill 192. And at this time, the board is not setting a UPL, but rather is gathering information to include in a report to the legislature approaches to a UPL. And we will capture any questions or concerns from this group as we are preparing our reports for the board. And so just some logistics. Again, when we get to that point in the session, we will ask that you introduce yourselves so that we can accurately capture your feedback in our notes. And in addition, we do have a pretty large group today, so we would ask that you please mute yourself when you're not speaking. When we get to the discussion portion, we are not able to answer specific questions related to methodology or affordability evaluations. But we will give you a mechanism to submit those directly to the PDAB for consideration. And so just as a refresher, this is a slide we looked at during the first session, and it's a conceptual representation of a potential UPL model, which is adapted from work that was conducted by Jane Horvath. And specifically, it's intended to illustrate the progression of the UPL through various parts of the pharmaceutical supply chain. And as a reminder, the concept sits between the manufacturer and the wholesaler. And so currently, as we all know, the supply chain is oriented primarily around a wholesale acquisition cost, or WAC, AWP, MAC, FUL, or other similar metric. And in their 2022 report to the Oregon legislature, the board describes their concept for a UPL in Oregon, including that it establishes a maximum amount that can be paid for a prescription drug, and a concept that's likened to the federal upper limits, the NADAC or MAC prices that are currently established and used in prescription drug reimbursement today. And so the proposed model would be for the UPL to replace these metrics for supply chain transactions along the continuum for a prescription drug product being dispensed or administered in a state when a UPL exists for a particular drug. And as noted in the diagram, the UPL is independent of dispensing or administration fees. And so now we will move into our group discussion. And again, as a reminder, please, if you would, remain on mute unless you're commenting. State your name and organization for us when you're making comments. And Zoom also has a feature to raise your hand. If everyone would please use that so we can make sure that we recognize everybody who wants to speak. And then, of course, written feedback, as I mentioned, can be provided as indicated on the slides. I will pop these into the chat as well, and I put 6/14, that should read 7/12 as a date to provide this feedback. Or you can provide public comment directly to the board using their form, and the website address is given there. And so, Bobby, with that said, I will turn this over to you to kick us off for the discussion.
Great. Thanks, Linda. Go ahead and get started. Just reiterate what Linda said. I want to thank everyone for taking the time to join us today, and for those of you who were able to participate in the last meeting. For those of you who did attend the prior meeting, we spent most of that time sort of talking about drug affordability generally, and the potential impacts of UPL just conceptually. Given we've got a number of new attendees on the call today, I wanted to do a little bit of a repeat of some of the questions from our last call, just to give folks an opportunity who weren't present to provide any input they might have. And then we'll move on to a discussion of UPL methodology specifically, and talk about sort of what folks might envision as a desired state, and then talk a little bit about or give folks an opportunity to provide any input on additional recommendations, UPL specific or otherwise, that they would recommend the board consider as they do their work moving forward. I think Linda may have said this at the outset, but just want to reiterate, we are recording. However, we're more than happy to shut the recording off if folks have comments that they would prefer not be included specifically in the record there in terms of the recording. And just also want to reiterate that the intent here is as a listening session. We really want to take the information obtained during these sessions and be able to share with the board so that they can leverage that to fulfill their statutory obligations to report back to the legislature on the UPL concept itself. So I guess we'll go ahead and jump right in. The first section that we discussed during our last call was just the impact of affordability in general, to sort of level set and understand the perspectives of each of the constituent groups. The question that we really started with was, the idea that there's certainly a widespread perspective across the country that pharmaceuticals are really out of reach for many Americans just due to their costs. And wanted to get your input, hear how your organizations perceive, the idea of drug affordability, generally, your organization's ability to impact or address affordability challenges that consumers may face. Talk a little bit about, whether you believe UPL could have an impact on that challenge that consumers face. So just want to open it up to folks who were not in attendance during the last call and see if you had thoughts or feedback you'd like to share, again, sort of on your organization's perspective on the affordability challenge specifically. If anyone would like to just jump in, feel free to either just jump in or raise your hand as Linda had noted through the Zoom function. Yeah. Is it Daria?
Yes. Hi, Daria McGrew on behalf of Pharma. And first, let me say thank you for allowing us to switch up our representative today to accommodate for schedules. So, I think that I'll start out from Pharma's perspective and then let some other folks jump in. But, I believe was discussed last time. I'll reiterate that, the core of the mission of our companies is to develop treatments and cures for patients. And if patients can't access those, then our companies can't do their work. They intend for treatments to make it to patients, to address unmet needs. And they do understand that, like I said, those treatments are only beneficial if patients have access to them. And the reality is that many patients can't access those. The biggest driver is insurance. We have an American healthcare system that is set up around insurance, and that is often broken and it's often unattainable. Working the insurance system to get the medicine you need is often unattainable, and those who do not have insurance must use safety net, must rely on the safety net to receive their care. So to address concerns of access and affordability, our companies have gone to great lengths to ensure patients who need those treatments and cures can access and afford them. We have patient assistance programs for patients who cannot afford their insurance set copays and coinsurance, so that they can access the medicine at a lower cost than the insurance wants them to pay. We have our MAT.org. Member companies have over 900 different programs available to help make that out-of-pocket cost more affordable for patients. There are also different patient assistance programs for patients who are uninsured, different pools of money for uninsured patients to be able to access medicine if they are not able to acquire it through other safety net programs. 340B and Ryan White programs sell low cost or donate drugs to clinics so they can mark them up and provide more services to uninsured and underinsured. That value was $52 billion in 2022. Of drugs that were sold or provided for free to those clinics. And most importantly to this conversation, as we're always talking about at the PDAB in Oregon and everywhere, is rebates and discounts. The price that the public sees when they hear about the cost of a drug, they're always referring to the wholesale acquisition cost or WAC, but that is not the price paid internally within the healthcare system. Our manufacturers negotiate significant rebates and discounts paid to, and those are to make the medicine more affordable to plans and to patients. The value of those rebates in 2022 was $256 billion. Those bring down the costs of medicine, and the net price of medicine has been flat or declining for over 5 years now. I'll let somebody else jump in.
Thank you for that. Other folks have comments? Yeah, Stacy, go ahead.
Hi, my name is Stacy Cole, and I'm attending from Genentech. Thank you very much for the opportunity to have a back and forth discussion or to share a little bit of information. I've been watching the process for the past year or so, and I think one of the most challenging things that you need to grapple with for UPL is just affordability to whom. And I've heard times where it's affordability to patients or affordability to health plans. And those are different questions with very different data sets. So thinking just about, for example, affordability to patients, right? And you may have an out-of-pocket metric that you show that's average, but someone's benefit design for the same drug could mean that they pay a 2 or 3-fold difference in their out-of-pocket just to their health plan. So making sure as you're looking, for example, at your out-of-pocket estimates, are you really understanding differences in benefit design? Are you understanding differences in the number of medications filled? But also, I think there's the importance of what are the other potential costs outside of just what your out-of-pocket cost is when you reach the pharmacy counter. So, for example, what if I don't have to take a day off work and drive every month for a treatment? And I didn't see a lot of that information included in your previous reports. So I guess just number one, really prioritizing, is it affordability to patients? And then secondarily, affordability to health plans? Because I think, like I said, that's different data, different considerations. And then as we dive into what affordability looks like for patients, just realizing some of the challenges and what goes into that mean or median out of pocket and how that can truly be very, very different, even for something with the same list price or the same net price. And bulking up to the extent possible information from broader stakeholders about what are the costs that we're not seeing. The fact that I have to take a rescue medication if I don't take this medicine, the fact that I may have an exacerbation that causes a hospitalization. And I think some of that's not really showing up in some of the reports that I've seen. And I don't know if that would come from listening sessions or a broader way to capture data, but just making sure that context is there when you're talking about affordability and we're not just focusing on a point estimate that has a lot of nuance that's really hard to interpret.
Are there, just to tease that out a little bit further, because we do have some questions later on, and maybe we can jump ahead a little bit, but in terms of those data points that you think would be most relevant to address some of those considerations, do you have any thoughts or recommendations for the board in terms of what they should specifically be looking at and considering?
Yeah, I think number one, for some of the data that you're getting from the APCD, just making sure you're looking at it, trying to understand, are we looking at patients with the same number of fills? Is there an ability for you to look at different health plans or different patients that might be on different benefit design structures, just to have some more transparent information on how much of what you're seeing might be driven by benefit design versus kind of the overall cost of the medicine? And then I think secondarily, maybe having a section where you can report, and allow manufacturers or anyone who's sending in data where they can talk about, additional costs that might be hitting the patient for their particular disease that should be interpreted in context. And some of them might be done with modeling work. Some of that might be total cost of care work. But I think just really bulking that up. And I loved the histograms that you had. I think that those really started to show the fact that it's really hard to look at a point estimate. But I think there's a few more layers that could be pulled back in terms of, are you looking at patients the same number of fills, the same number of continuous enrollment? Are you looking at them at the same amount of time where maybe their deductibles have and have not kicked in? And really just maybe setting up some best practices for how you want to see that out-of-pocket data come to you when you're doing that call from providers as well.
Thank you. On that particular point, do others have thoughts, Daria or others, in terms of kind of some of those more granular data points?
Yeah, sure. I think Stacy was bringing up a good point about what the PDAB has done so far and has, really begun to dive more deeply in, but, has also recently recognized that they're lacking a lot of data and, took a pause and a need to go back to first principles on this. As Stacy mentioned, affordability for who at the board, the board acknowledged they want to reconsider that. So, I want to separate out talking about a UPL, data points for a UPL. We're not there yet. I don't think the state is there yet. I think the state really has to go back and does intend to go back and do better work on the PDAB. There, the analyses so far have lacked data, so they really have to go back and look at what data are available and what data they need. What are the questions that need to be asked, and then look for the data based on those questions, not based on foregone conclusions, but really going back and digging in and doing a deeper dive on that data.
But they're thinking about this constituent group in particular. Are there particular data that would, I recognize that the proprietary nature of certain data, contractual obligations to, maintain confidentiality of certain data. Are there data points that, you as a constituent group may have access to or think would be beneficial to share with the board, or that you would be able to share with the board to support some of that work? Data is always the challenge, right? So I think that, from the board's perspective, I don't want to speak for the board, obviously it's not my role here, but, just being able to access and get to some of the granularity, I think is certainly a challenge for entities in, kind of trying to work through these issues.
I'll pausing so I'm not taking up other people's speaking time, but I'll just say that I think that one thing that has been lacking in the reports so far, and I hope that the board will dig further into, is burden of disease. A lot of the conversations have started from the presumption that medicine is a problem and is forgetting, well-known, well-recognized that medicine is a good thing in our society. It reduces healthcare costs. It improves people's life. It improves their ability to work. It improves society, and that can be quantified for many conditions. A lot of work has been done on the burden of disease. So when plans are saying that their medicine costs are too much, I think that the board should ask the plans about the savings from medicine. What other conditions, Stacy mentioned rescue or, intermittent outbursts of diseases. So, what savings to the other parts of the plan are realized when patients have access to medicine or patients are able to adhere to their medicine.
Thank you for that. Stacy?
I should caveat that I'm our team's data person, so I should apologize for bringing all the data questions today.
No, that's a great direction for the conversation. I really appreciate it.
Great. I'm just sitting in for Kitty Chandra. In terms of data, I think number one is just being more granular with some of the APCD data that you do have, making sure you're comparing apples to apples. Am I looking at, my median and my interquartile ranges for patients that have had a similar number of fills, right? It's really hard to have somebody in month 1 versus month 12. I think in terms of your data call, asking for more granularity there. What does the copay look like for patients on these plans and these tiers? Just to really help to kind of demystify that average. And then to just reinforce the point that Daria put out, these are disease areas where health economists and others are doing research continuously to talk about burden of disease, to talk about overall cost of patients. Now, of course, you could do a survey, but I think that's probably a lot of work for a de novo effort. But if you look at a study for multiple sclerosis, it'll talk to you about, what do we see for productivity? What do we see for these other elements? And it could be a very simple targeted literature review just to add that additional context. And then, of course, through, robust engagement with stakeholders, you can help to refine that. But I think it's really hard to only have bits of data that are medians or not have some of that information about what do we see overall beyond a net price or beyond a WAC or beyond out of pocket. And I think, like I said, a targeted literature to really highlight burden of disease and burden of maybe overall patient burden of overall patient expenditures for their disease.
That's great. Thank you very much for that. Chris, go ahead.
Thank you, Bobby. Chris Herbine with Johnson & Johnson. I spoke somewhat last time, so I didn't want to take other people's time, but I thought I could add a little bit to your question that you asked around data that could be provided. We talked earlier about the fact that insurance benefit design dictates patient out-of-pocket costs. So because the pharmaceutical manufacturers provide rebates, which reduces the overall list price of the drug to a net price, that doesn't always get passed along to patients to reduce their out-of-pocket costs. So what ends up happening then is the manufacturers have to find other means to support the patient because that hasn't been passed through. So what I would encourage you to look at, and I know Johnson & Johnson has submitted as part of the focus group survey, as well as in our original submission around one of our products, Tremfya, information around our patient assistance programs, our copay assistance programs, and what that does to improve the affordability of medication to the patient. And we submitted data around our programs and the number of patients we've supported to reduce their overall out-of-pocket in a very significant way that it's very affordable for patients. So I would just urge you to consider manufacturer-submitted data around patient out-of-pocket assistance and what the programs are doing to relieve that burden for patients.
Thank you for that, Chris. I want to just a quick question, and I guess I would pose this to everyone around the patient assistance program issue. And this is not me necessarily having a particular opinion, just sort of some things that seen in the literature and whatnot. So I'm just kind of looking for your kind of response to. I know I've seen several peer-reviewed pieces in JAMA and elsewhere that have suggested that patient assistance programs could actually lead to higher drug prices, just given sort of the interplay between patient demand and pricing and things like that. Have you seen those? Do you have thoughts around sort of those studies were maybe not designed appropriately, or we don't agree with underlying economic assumptions? Any response to that?
I think it really comes down to addressing the underlying root causes of the system that are impacting patient out of pocket. And if we get to the root causes, all those problems can be remediated. And yes, they're all intertwined, and one could impact the other for sure. But I think, what I think we're trying to say is if we get to the root cause of the issue and fix that, then all these other problems that are adjacent to it and linked to it could be remediated as well.
I apologize. I know that I just saw a hand up before I asked that question and it went down. So I don't want to skip over someone if someone else had a comment. Yeah, Alyssa.
Sure. Yeah, I didn't want to take it back in a different direction if you were heading somewhere else, but I did have a couple things to say just on the data portion that we were talking about before. I did want to add that I think recency of data is a challenge that we recognize, but also something that we've seen play out in the PDAB's work to date. So just for example, I think that there should probably be a more concerted process for trying to exclude drugs from review that have faced patent expiration since the most recently available data. So I know that I work with Takeda, and over the past year, Oregon continued to keep Vyvanse on the affordability review list, even though patent protection and the associated regulatory exclusivity period from FDA had expired in August 2023. I think that's because the data that the PDAB was using was from 2022. So I think that's just an example of how recent data or lack of recent data can impact the selection process. And I did want to respond to one of the other questions you posed about information that manufacturers might be able to offer. I know Chris was saying that you should look carefully at the information that manufacturers provide, but I do think, one of the things that is distinct about the Oregon process as opposed to maybe some other states is that there isn't a process for submitting confidential information or having discussions or sharing data with the board that would remain and be kept confidential and protected. To date, all of the information submitted is public information, and for a lot of reasons, there might be hesitancy across the manufacturers in providing all of the necessary information around whether it's assistance programs or rebating or what have you, without some of those protections in place. So I did just want to highlight that if that's some of the data that the board is looking for, I think having a process for submission of confidential information would be important.
But that's a great point, Alyssa, and something that kind of popped in my mind as we started talking about this. I'd be curious if others on the call, if that's something that, if a process did exist, that did allow for some more of those confidential discussions around data points that are closely held. Is that something that others would be amenable to, would be interested in? Go ahead, Chris.
Alyssa makes a great comment, and we've provided what we could, but obviously there's limitations. So I do agree with her 100% that if that pathway existed, it would be helpful.
I'll just add, as the trade association, I can't speak for any individual company, but that is something that we have consistently asked for in our comment letters to the PDAB, is a mechanism for companies to submit confidential information and confidentially request corrections to the data when they see errors.
Great. Just for so I capture this appropriately, Daria, is that in formal comment that you've submitted to the board through the existing mechanisms, or something that?
Yep. Nope. All of those letters are on the board website. Happy to provide them as well.
Nope. That's perfect. I just wanted to confirm. Thank you. Michelle?
Hi, yes, Michelle Droz from Gilead. Thanks for the opportunity to speak today. I just wanted to follow up on the question about data and data sources. One point that we've suggested in some instances is using IQVIA data, which provides a level of detail you don't get from the all payer claims database around secondary payers. And that's important in diseases like HIV, where you have both manufacturer assistance, as was discussed, but also federal and state programs that are helping support patient affordability. And that's why we've seen such robust affordability for HIV medicines like Genvoya in the state. So just wanted to share that. Thanks.
That's great. Thank you for that recommendation. Any other thoughts on this general topic before we move on? I want to be mindful of the time we have. Go ahead, Jack.
Hi, this is Jack Geiser from Bio. I want to first of all echo Daria's points on the confidentiality and Alyssa's and such. We have also been stressing the need for confidentiality in general, and one of the other things I want to do is sort of underscore the points Chris was making about the root causes of this of the issues related to affordability, and in particular, I would also point you to the FTC's interim report that was issued yesterday on PBMs. This is a study that began back in 2022. And some of the key findings there really reinforce the need to look at the supply chain overall. But in particular, the PBM market has become highly concentrated, and the largest PBMs are now vertically integrated with insurers and pharmacies, and they have a major impact on affordability. And the report particularly says that the PBMs exercise a significant power over Americans' access to drugs and the prices they pay, and that's a direct quote there. And I think it's important to recognize that PBMs do have significant impact on affordability and how that plays out for individual patient access. And when you think about the number of insured in the state, it's very high. So you're really talking about how insurers, how insurers receive or pay for medication. And, that's something that we've been strongly emphasizing generally. And I would reinforce Chris's comments about, how about PBM pass-through of rebate dollars, and patients should receive those discounts. And they aren't currently in particular in the state of Oregon. There are some states that have done that. So we do support that initiative.
Thank you for that, Jack. Linda, I'm going to put you on the spot for a second, if you don't mind. I know that's something that the notion of pass through, to the point to the consumer has been something that we've talked about and heard in other constituent discussions. Do you have is there any questions you might have on that you want to tease out?
Oh, yeah, actually, thanks, Bobby. That's a really good question. If we could dive into that a little bit, I think we would be interested in understanding how something like that might be implemented. It's not real common across the country. I believe West Virginia has something similar in place. And certainly we know that there's action around this, in the Medicare space, but to date, there have been concerns about complexity, for example, with implementing this. So it would be interesting, I think, for us to hear what recommendations or suggestions you might have about how rebates might get passed back for example, at the point of sale, or is there a better way or a different way?
Go ahead, Jack.
We look at it from a perspective that should be at a point of sale, and that can be adjudicated through the PBM and such. I do believe there are others that probably have more expertise in terms of how this has played out, quite honestly. But we have supported the efforts of or I should say the legislation itself that was was introduced and passed in West Virginia, but I know that there are other states where it has been introduced and did not necessarily pass. But I know that there are others that have more expertise on that than I do, quite honestly. And I believe Daria has her hand up.
Happy to jump in here.
Yes.
Yeah. So Daria, we'd really be interested in kind of the practical thoughts around how that implementation might work.
So I'll just start with saying reports of the complexity are greatly exaggerated.
Okay.
Many of the PBMs or the plans advertise this as a function that they can turn on for clients. We have, happy to provide documents where they have advertised it as an optional add-on that they can just, this can save you money for your employees if you would like to do rebate pass-through at point of sale. There are some states that have implemented it for their state employee plans. So it is a computer programming switch that can be switched on and off at the end of the at the PBM or plan end, and they are capable of doing it and already do so, and in much the same way that the pharmacist types in the computer and can look up can know what your copay is right away. That can be programmed in. The rebate can be factored in there. To your question about states doing it through legislation, there are now 3 states that have passed it, West Virginia, Arkansas, Indiana. West Virginia is fully implemented and has had no problems. The state regulators reported, I think last year, that there were no problems with implementation. And Avalier, I believe, just put out a study showing no negative impacts. One of the criticisms has been not just complexity, but also that it would raise premiums on everyone. And multiple analyses from us and other organizations have calculated or anticipated a minor 1%-ish, we're talking dollars per month premium increase, and real significant savings for the patients who benefit from it. The patients who are in high deductible health plans can save hundreds to, maybe $1,000 per year at those point of sale costs. And so now we have real world data from West Virginia, being the first state to implement this legislatively, that did not show any significant premium increases due to passing on those rebates.
Yeah, and in all fairness, I think some of the criticism around the pass-through on rebates is probably directed a little bit more to more of the Medicare space than the commercial space as well. We're talking about very different, a very different type of repayment. Okay.
Others have thoughts on this particular discussion topic?
So if we could, I know we have a lot of questions we'd like to get through, Bobby, but if we could go back to something Daria said just briefly, hopefully, earlier about rebates. So is there any kind of a figure that you could share, sort of a range perhaps, of how the rebates, how much of the rebates, for example, 60 cents on every dollar? I mean, that's obviously probably a little high we're talking about, but do you have any kind of a figure on how much the rebates that we don't see are impacting the system? You mentioned that being a source of I guess discomfort.
Yeah, can you clarify?
Sure. Well, we were talking earlier about the rebates that were going back to plans, and that being a figure that's not public. Yeah. First off, is there any kind of information you could share with the board about what an average or a range might be, particularly for the kinds of products that we tend to be talking about today? So obviously we're not super concerned with generics, right?
Yeah. So it's a great question. You know, the individual rebates are confidential.
Right.
However, we do have, you know, there's a lot of data out there about average rebates and even into specific markets. And now coming out of states like Oregon, we're getting, you know, much more insight into specific rebates across product categories. So, you know, generally speaking, the number that we say is on branded medicines, the rebate is about 50%. Depend, and that it does vary widely
Sure.
across different products. But, you know, we say in total, our member companies are rebating $256 billion just last year, and that number goes up every year. So those rebates, but, you know, we know that in very competitive spaces, for drug markets where there are lots of different drugs on the market, those rebates go up to as much as 80% in competitive markets. So that variation is very wide. I would point you to information, you know, coming out of Oregon PDAB, where they have information from the data call that is giving a lot of insight on what those average rebates are. We don't want disclosure of individual rebates, but we are getting a lot of information about average rebates these days.
And I know, understanding, of course, the confidentiality, and we talked a lot about that. Is rebate information the kind of information that you would be able to share or willing to share with the board, assuming the appropriate confidential constraints were in place? Or is that something you'd have to think about?
I can't speak for any individual member companies, but those are protected through contracts between the plans and the individual manufacturers, and would not be something that disclosed.
Okay. No, that's helpful. That's helpful. I think that they're seeking to understand what kind of information they can seek and reasonably expect to receive and not. Okay. Thank you.
But I will add that through the data call, the Oregon PDAB did acquire broad information for drugs across plans, and so does have at their fingertips quite a bit of that information now.
Chris, go ahead. You had your hand up.
Thank you. Appreciate it. I just wanted to add to the discussion, Linda, the question you were asking. Johnson & Johnson on an annual basis publishes a transparency report, where we publish, you know, the aggregate list price of our drugs and the aggregate net price. And the most recent data published publicly, we highlighted that 58% of the list prices of our medicines went to commercial insurers and others in the healthcare system. And the data supporting those figures are publicly published. I think we included in a link in our focus group survey feedback, but if not, I can certainly provide that through the email address that you highlight on the screen here. So it's just a reference point that kind of aggregates the data so that we're not divulging anything proprietary with one individual customer, but it does give you a good perspective on, you know, a large subset of the pharmaceutical business.
That's great. Michelle?
Thanks. I just wanted to add to the rebate discussion that rebates are just one of the many types of discounts or price concessions that manufacturers provide on their medicines. And so one that maybe is worth also discussing a little bit is the 340B discount program. We noted that the UPL approach fact sheet that was put out by the board was stating that 340B covered entities would continue to make margins on outpatient drugs with a UPL, but we're still trying to understand how the UPL would impact the margin that those 340B entities are making. Because if it's lowering the reimbursement, it could, and the price they're buying the drug at doesn't change, then you're actually reducing the margin for the providers, and the price that they buy the drug at is confidential. So I'm not sure how you could even guarantee that that they're going to continue to make that margin. So it's just another illustration of how the supply chain is really complex. And when you try to step in and implement something like an upper payment limit, that can have significant knock-on effects throughout the supply chain. And 340B is particularly large in HIV, which is why we've been paying attention to it, where there's public data out there that 40% of HIV sales are subject to 340B discounts, which is much higher than the overall market. So just want to provide that. Thanks.
Thank you for that. Linda, any other questions on this line?
No, nothing else for me. I'm going to let you move on because I know you have a lot of other questions.
No worries. Want to be mindful of everybody's time. I think what I'd like to maybe spend the duration talking about is, we've been focused, this discussion, obviously, the purpose of the discussion was focused on UPL, but the board is also very interested in other recommendations that constituent groups have, that they should be thinking about or looking at or recommending as policy in the legislature beyond a UPL. So, I want to kind of open it up to this group to just kind of ask from your perspective, are there other things that you believe the board should be considering, focusing their energy on, really sort of trying to peel back and understand and recommend in terms from a policy perspective beyond a UPL, other ideas or recommendations that you might make to the board to consider. Go ahead, Daria.
Thanks. Thank you for asking that question. I think, you already did ask about share the savings, what we call rebate pass through. That is a big issue. Jack mentioned PBMs and their influence, the FTC interim study that just came out. This is not new. It's been growing concern about the influence and the size of corporations in the healthcare space and this vertical integration. The Oregon Secretary of State published an audit last year that highlighted some of the problems with PBMs, and the state legislature for several years now has considered multiple bills and had multiple hearings on the matter. So there's been a lot of interest in understanding better the influence of PBMs and how they're impacting healthcare costs. From our perspective, PBMs are soaking up money out of the healthcare system and turning it into profit instead of improving the healthcare costs. And, there are several policies that the board could consider as it pertains to PBMs. There are proposals that PBMs should be required to act in the best interest of their patients. That's been considered and passed in several states. There's also a lot of work done on misaligned incentives, where PBMs are incentivized to choose a higher list price and to negotiate a higher rebate rather than picking a drug that just starts off at a lower price, because their fees and their incentives are based on that rebate amount or that list price amount. They're selling a higher drug, they make more profit margin. So, there are policies that we would propose to disconnect compensation from the PBM's compensation from the list price, and to disrupt the dynamic that incentivizes them to drive up costs instead of saving costs. And we believe that would save money in the healthcare system.
Thank you for that. Others have thoughts in terms of other policy strategies that the board should be considering or recommending to the legislature? Well, let me just we've kind of bounced around a bit, which is great. I think it's been a good discussion. I really appreciate all the feedback. Let me take just a second here and sort of look through my notes and see if there were any particular questions that we haven't discussed or that haven't been addressed that want to make sure that we touch on. One thing that has come up in other constituent groups, and I think we touched on a little bit during the last call, a number of the other constituent groups have expressed concerns that, you know, setting a UPL would create access issues, specifically, patient access to medications. You know, and specifically concerned that, you know, Oregonians may not be able to access certain medications. Do you believe that's a valid concern? You know, are there steps that could be taken to ensure that, you know, the supply, if a UPL were implemented, would sort of not limit access in the state? Thoughts around just the access issue in general? Yeah, Jack.
Yeah, hi. You know, Bio's been looking at that a lot, and we really do believe that access could be seriously threatened with UPLs. And one of the reasons is that there are, you know, if a UPL, for instance, does not reimburse fully for the services that are provided with the drug itself, then reimbursement is closely tied to providers with specialists, for instance, that want to provide a particular type of drug, but that can only be provided in the centers of excellence, for example. And, you know, if they're not getting their full reimbursement for all the services they must provide in addition to the drug, then, you know, their incentive to provide the drug is much lower. So if they're not providing that drug, then patients will not receive access to those drugs and would need to possibly travel even out of state for them. So, you know, you have, you know, significant problems with that type of situation. And, you know, we really, you know, feel that, you know, there are, you know, lots of other issues that need to be resolved with this. Would be, for instance, even for testing of services and that type of thing, even before they get access to the drug. So these are things that need to be resolved if they were ever going to implement a UPL. And you can't guarantee that every insurer, for instance, is going to reimburse adequately for the services.
Thank you for that, Jack. Dorian?
Yeah, I'll just add on, you know, this is an issue that we have consistently raised, and not just us, but a lot of other supply chain entities have raised concerns about inadvertent impacts on access. You know, adding on that, you know, a lot of entities purchase their drugs in bulk on a national scale and then disseminate locally based on actual orders. So, you know, a big outstanding question for us is how will they purchase drugs, only Oregon drugs versus the rest of the country drugs, if the Oregon price is set differently than what the accepted price is everywhere else in the country, and will that have impacts on their ability to bring drugs into Oregon? You know, and I'll speak personally. You know, I think that a lot of us have experienced difficulties accessing medicines or jumping through hoops. You know, I've had to try several different medications to find the right match for me. I think everybody has a family member or has gone through this, where you've worked with your doctor to try different medications to end up with the one that works for you. And the drug that is on the formulary or the preferred drug of your insurance plan may not be the right one. And for me, I was able to jump through the hoops of utilization management and achieve able to access the drug that I needed. But a UPL would add another layer of complexity to an already difficult system. You would be adding the state as an adjudicator of whether that is the right drug for the patient, on top of already fighting with their plan or their PBM to get the drug that they need. And so adding additional middlemen between a patient and the medicine that they need can cause access problems.
Hey, we've just got a couple minutes left. Any other thoughts on the access issue? If not, I know we've talked about a lot today. We've got a lot of great information. Really appreciate the dialogue and the input you all have provided, not only during this call, but during the last call. Anything just in the remaining minutes that we have that you want to share that we didn't ask or that you were hoping we would talk about? Just want to make sure we use this opportunity to capture input you were hoping to provide. Yes, please, Caitlin.
Hi, Bobby. My name is Caitlin Lucarello. I'm a Deputy Vice President of State Policy with Pharma, and I've been on a fly on the wall for both of these conversations, really just listening to, the dialogue. And I want to, first of all, thank you for having these upper payment limit conversations, for thinking about implementation and outcomes before you set an upper payment limit. That hasn't been a consistent process in all states. I think as Daria mentioned, we certainly have concerns about access issues, particularly after hearing operational concerns from the supply chain and how an upper payment limit would be implemented within the existing structure of the supply chain today. And so I want to just mention a couple of things that have come up for me in terms of operational considerations that you can respond to or maybe capture for the board's discussion, and just come back to a few assertions that were made or have been made about pricing metrics, which I think could be particularly impactful for access. I appreciate that Michelle brought up the 340B issue, and I would really appreciate the board opining on how, if this 340B ceiling price would be set at or below the UPL, how you would ensure that that would be the case. And I think similarly, we've heard in the first focus group that an upper payment limit is also not intended to affect best price. So how will you implement the upper payment limit in a way that doesn't affect best price? I think another example is we've heard that the UPL will not affect Medicaid rebates, but even some state Medicaid programs have expressed a concern that a UPL could negatively impact federal matching dollars. All of these things also speak to access concerns. And I think we've heard these assertions made several times here and other materials and other conversations around upper payment limits, but there's really been very little detail to provide support that there won't be impacts to those federal pricing metrics, and particularly around pricing metrics that are not public. So I want to make sure that we capture that concern in this conversation today.
That's great. Thank you for that, Caitlin. I appreciate you taking the time to join us these past couple calls and weigh in there. Okay, so we're right at time. I want to be mindful of everyone's schedules. Any last comments that folks want to share today? If not, I believe Linda put it in the chat. It's also up here on the screen. I know it sounds like you all have or are familiar with and have submitted a lot of input to the board already via the formal mechanism through the website and some of the sessions that they've held publicly. If you do have comments or thoughts, sort of in response to this discussion, feel free to shoot them to us at this email that Linda has up at mslc.com. We'll certainly incorporate the feedback you have in our report back to the board on all of these stakeholder sessions. And again, just thank you for your time, and hope everyone has a great rest of your day.
Thank you.
Thanks, everyone.